In this lecture, we're going to address the question, are we in the middle of a paradigm shift in the way we diagnose glaucoma in the clinical practice? Short answer is, I sure hope so. Here's the outline. First, I'm going to describe what I believe is the most common clinical paradigm of tests done currently to diagnose glaucoma. Then we'll discuss three driving forces behind a paradigm shift, and then finally some of the implications. So I think the most common clinical paradigm or collection of tests done to diagnose glaucoma include the following: a physical exam of the disc, often accompanied by a photo, fundus photo, or in some cases stereo photos. In terms of visual fields, a 24-2 or 30-2 visual field. And then for OCT, a disc scan, usually in the form of a cube or volume scan. And in terms of analysis of these data, the clinicians depend primarily, in the case of the OCT, on metrics, in particular average retinal nerve fiber layer thickness, and the chart here, pie chart of abnormalities by quadrant. Excuse me. The metrics are also commonly used for the visual field, in particular the glaucoma hemifield test statistic and pattern stand deviation, although clinicians also look at the distribution of abnormal points on the pattern deviation. All right, so are we in the middle of a paradigm shift? So I'm going to argue yes, and there are three forces that are driving this shift. First of all, we now know that macular damage is common in the earliest stages of glaucoma. So from Module 5, we discussed the superior vulnerability zone and the inferior vulnerability zone, and I argued that damage to the macula was common in this study we published, over 80% of the eyes. And about 3/4 of them had damage in the macular vulnerability zone. So 87 for the whole macula here, and then 3/4 of the total. So most of these had damage that included this region here. This creates two problems for what I call the common clinical paradigm. The first problem is that the OCT analysis of disc scans can miss macular damage. So here's an example from one of our publications. Here's Here's a report that would be read as normal based on the metrics. Here is our lab report for the same eye, and you can see, although this region here does not fall in the red, right? Same thing here. There's a clear chunk here out of the retinal ganglion cell. That is, there's retinal ganglion cell damage in the same region you'd expect from the thinning here. And then here you see it on the probability map in field view. Okay, so the solution to that problem is it's essential that when you're getting OCT tests, you include not only the volume scan of the disc, but you also have a volume scan of the macula, so that you can look at retinal ganglion cell thickness and probability maps. So this goes back to the 5 principles behind our lab report. And principle number 3 was to detect glaucomatous damage to the macula, you need retinal ganglion cell thickness maps of the macula. You need this right here. Principle 4 behind our report was that you want to examine not only the thickness maps, but you also want to examine the probability map of both the retinal nerve fiber layer and the retinal ganglion cell. So here, I'm going to examine the probability map in field view for the retinal ganglion cell, and you can see the abnormal region that corresponds to the thinning. And then you also want to look up here at the retinal nerve fiber layer, and you can see that there's damage here. All right, the second problem is that the 24-2 or 30-2 visual fields, because they have such a gross grid for testing, remember the points are spaced every 6 degrees, you can miss or at least underestimate macular damage. So here's an example. It's not unique, although it may be extreme. There are a number of studies that have documented that the 24-2 can miss or underestimate damage. So here's, in this example, the damage has been missed. So here's the 24-2, it looks normal. Here's the 10-2, you can see the deep defect. And the reason for that is that the center points here are missing most of the damage. In this particular case, this damage here is falling actually between these points. So, right, the solution to this problem is to obtain 10-2 visual fields or modify your 24-2 pattern. All right, so the second driving force behind a paradigm shift is the increased resolution of OCT images. They've improved significantly. So this is an example of what was available with the time domain machine 10 years ago or so. New images are much better than the original machine. In fact, they've been better for 8 years or so. This scan here is from a spectral domain machine, but it was obtained about 8 years ago. And these hyperreflective regions here that you see here and here, right? We know, as discussed earlier, that those regions correspond to preserved bundles. So wherever there are, this is adaptive optics, wherever you see preserved bundles on the adaptive optics, you see a hot spot. Where you see no bundles, you see dark. So you can see regions of preserved retinal nerve fiber bundles on the OCT. Remarkable detail here. There is so much more information available in the OCT scans than available in summary metrics or the typical glaucoma reports, and I'll say more about that later. The common clinical paradigm ignores these details. So, in short, clinicians are not making optimal use of this incredible technology. And again, going back to our principles behind our report, we had a circumpapillary image here that was large enough so you could see details. Whereas typically in these reports, it's either missing or it's so small as to be useless. All right, the third driving force behind a paradigm shift is an awareness that OCT and visual field summary metrics miss clear damage. So here's our contribution to this literature that's slowly building. You might remember that this was a study in which the 2 glaucoma specialists who were not involved in the care of these patients agreed on 102 eyes. They called 57 glaucomatous, 45 healthy suspects. Right? Based only on the OCT report, I was 98% correct. I got only 2 wrong. Now, the point here is not look at how good I am. The point is how much information is in this report that only has the OCT in it at the moment. This performance here was much better than any of the existing OCT metrics. For example, out of the 102, I had 2 mistakes. The 30, if you depended on the mean deviation of the 24-2, you would have 30 mistakes. If you depended on the pattern standard deviation, you'd have 20 mistakes. If you depended upon the glaucoma hemifield test, you'd have 21 mistakes. And if you used the Oates criteria of this or this, you'd have 20 mistakes. OCT was better, but still, I made 2 mistakes. And again, it's not about me. That is, the information was available here that was much better than the metrics. So while I made 2 mistakes, quadrants, using the quadrants here, which did the best, had 13 mistakes, clock hours 14, and global average 15. Okay, so OCT and visual field summary metrics miss clear damage. So again, 5 principles behind this report. Principle 5 was damage can be confirmed by topographically comparing visual field probability maps, making use of both the 10-2 and the 24-2. So that's what we can do here, where we've superimposed in field view the locations. You can't tell whether this is normal or abnormal. You've got to get that information from the visual field, but this shows you the location of the 24-2, open circle 10-2. And this is the location of the 10-2. All right, once you have the fields, you can now circle this, and you can see the topographical agreement. Same thing here, topographical agreement. And in many cases, the metrics will not show you that. Okay, principle number 2 we make use of, that is relevant here also. The scan and the circumpapillary retinal nerve fiber layer thickness plot should be shown as N-STIN, not T-SNIT. So that's N-STIN, right? So that defect there, you can see is going to be in the macula. And it corresponds to that and that. All right. We're now capable, as we've argued in an earlier lecture, being more precisely locating regions of the disc that relate to different regions of the visual field. And so this is the schematic that you may want to review, so that as long as this is in an N-STIN, this is fixation, corresponds on average to fixation. That would be right about there. And then here is the region associated with the macula. And then this is corresponding points. And these red and blue arrows are the region that corresponds, of the disc that corresponds to this part of the thickness plot. It's about a process or a method that's based on analysis that does not depend upon OCT or visual field metrics. Well, it's often said that structural damage precedes functional damage. So you've often seen in lectures plots such as this, where this is relative loss of vision or ganglion cells or retinal nerve fiber layer, and this is time, and it's meant to indicate that the functional loss, as measured, let's say, by a visual field, isn't changing, while the structural loss, let's say loss of retinal nerve fiber layer, is. This is a gross oversimplification. And here are 2 review articles that summarize the arguments involved. But for now, I want to make the point that in practice, whether damage is seen or detected first on structural or functional tests depends upon, first, the test used for function. Is it a 24-2, 10-2, Goldman field, etc.? And the test used for structure. Is it OCT, fundus photos, HRT, etc.? Second, the metrics used. How are we measuring the change in structure and function? And then third, the baseline values of the metrics for a particular patient when healthy. Now this is a very subtle point, but an important one. I'm just going to mention it now, and I'll come back and give you an illustration later. So we've argued, or Randy Carden and I argued, that which test comes first actually depends in part on where the individual started out life. So suppose I started out with a relatively thin retinal nerve fiber layer, normal, but on the thin side. And I was very sensitive because I'm just a sensitive guy. No, I'm more likely just a practiced psychophysical tester. So I had a pretty good high but normal sensitivity. You, on the other hand, suppose you started out the reverse. Your sensitivity was just so-so on the 24-2, but your retinal nerve fiber layer was really robust and thick. If we both get glaucoma, it's going to show up first on my OCT and first on your visual field because of where we started. I'll come back to that. All right, should we expect it to agree? Yes, we should expect visual fields and OCT agree in most, nearly all cases, if you topographically compare abnormal regions on visual field to those on retinal ganglion cell and or retinal nerve fiber layer probability plots. But they won't agree if you only use 24-2 test pattern, In some cases, you're going to need a 10-2 pattern. It won't agree if you only look at the pattern deviation plots and ignore total deviation plots. In many cases, the total deviation plot is more accurate or veridical. And it won't agree if you use typical 24-2 or 10-2 metrics. So again, I want to argue that typically structure and function agree and defects are clearly present on both if you look at the abnormal regions. So here's a very common example where you've got fairly extensive damage here. It shows up on the visual field as relatively early glaucoma. But let's circle the points. Those points correspond to there, those points to there. All right, well, that looks like reasonable agreement. It's even better if you look at the 10-2. If we circle these points on the pattern deviation here and circle the same points here, you can see the beautiful match. We can do this instead if you want. This would be the deepest part, and that corresponds to the deepest part. So this defect here is topographically the same as this, and the same as that, and the same as that. Whereas this defect here and this also. This defect here is topographically the same as this, and this on the visual field, and so on. And sometimes structural damage will appear. Sometimes structural damage will appear more obvious than functional damage, but you're still going to see agreement. So here's an example. The 24-2 here is clean, right? So the metrics are normal. If you blow it up, this looks normal. If you take a look at this defect and you see where it's falling in comparison to the 24-2 points, you see why. If we draw this to scale, it's falling right between these points. I mean, these points are separated by 6 degrees. That's a lot. Look at the 10-2. Again, the statistics are normal. The metrics are normal. If you blow it up, the largest losses are right here, and that corresponds with this. Or you can reverse it and this. Or you can reverse it if you circle this region here and ask where it is on the field. There it is. It's probably a better way to do it. Okay, so note in some cases you're going to need a 10-2 if you want to see agreement. Also, it's true that total deviation plots will often provide a more accurate picture of damage than pattern stand deviation plots. So here's an example. This is clearly abnormal. The retinal nerve fibrillary is down everywhere just about, right? If you look at the statistics here, that's borderline, that's normal, right? Mean deviation is down, right? But if you pay attention to this, you're making a mistake. For an eye such as this, the total deviation plot's the one that matches the visual field better. It's even possible to see the reverse. It's less often the case, but you can see examples where functional damage, meaning visual field damage, appears more obvious than structural damage. So here's one I would argue falls into the category. So you notice that that's borderline, but these are significant here. All right, let's blow this up. I'd say this is a pretty clear defect here. Same with here, by the way. But let's take a look at this one first. That corresponds to this. So this very subtle stuff here, which you could almost dismiss as an artifact perhaps, but this very subtle stuff here is clearly abnormal. Same thing. I believe this is clearer than what you see here. So this, by the way, corresponds to this location over here. So you can see it's borderline. And this corresponds to the location here, which is in the green, or this part here is borderline. All right. Now to understand what's happening in this eye, take a look at the other eye. The other eye is healthy, has normal visual fields. So let's take this and superimpose it. Right? So this is the affected eye. This is the normal eye. So this was an example of an eye that was more like you in the example I gave earlier. That is, I think what happened here is this eye here started out life like this, started losing tissue, showed up on the visual field, and then eventually will show up on the OCT. However, it's true that pre-parametric eyes are relatively rare if you don't define pre-parametric by metrics, but you define it by abnormal regions. So here's an eye that's pre-parametric, that actually is pre-parametric, closest one we could find. So this is within normal limits, that's normal limits, that's all normal, that's normal, normal. There's a suggestion of a defect here. Okay. There's a point or two here that I believe is real, though I would never call it based on this. Here's the visual field 8 months after the OCT and 13 months after this visual field. You can see it's still normal by the metrics, but now there's a clear nasal step that corresponds to these points here. So we're picking up a defect here, which is borderline over here. So that you may or may not want to consider this pre-parametric. It just depends. You had to wait a little bit longer for the visual field, but this is really relatively rare. By the way, this really is glaucomatous, and you can actually see progression. So this was 2013, and here's 2013, and here's the thickness plot for 2017. So that area is progressing, and it's in the macula. So you're not seeing that entirely, but there's also damage here too, and there. Okay. So, yes, in most cases it's going to, structure and function will agree, but not if you use the typical metrics. All right, so again, this is about a process, and let's now turn to a second misconception, and that is that you cannot use OCTs for advanced glaucoma. Right? So I'm going to argue that OCT is useful for eyes with advanced glaucoma. But to use it for advanced glaucoma, you have to ignore metrics such as global and quadrant retinal nerve fibrillary thickness, because they're going to approach asymptotic values. And you want to look at circle scans as well as retinal ganglion cell and retinal nerve fibrillary maps. So here's a nice study that supplies the kind of data behind the argument you can't use it for advanced damage. And I should say, in fairness, that we've published, my lab has published a number of studies that also can be used to make the same argument. So what you're looking at here is each dot's a point, and on the y-axis here is the mean deviation of the 24-2. Here is the average retinal nerve fibrillary thickness of the OCT. I'm going to flip this because this is the way I'm more used to seeing it plotted. And this, again, is the thickness, the average thickness of the retinal nerve fiber layer. This would be thick, this would be thin. This would be good visual field, that's 0 dB loss. This would be poor visual field, that's 30 dB loss. And this would be a 15 dB loss of mean deviation. So what Medeiros et al. Found, and what we found, and Randy Carden and I found, and others have found, is that once you get losses more than 10, 15 dB, the average retinal nerve fiber layer tends to asymptote. You can see that all these points are just scattered around an asymptotic value here of 55 microns or so. All right, so we just started a study of 36 eyes from 30 patients with mean deviations on the 24-2 worse than minus 15 dB, less than minus 15 dB. In fact, they range from minus 15 to almost minus 32. And the global thickness ranged from 64 microns to 28 microns. So This was the range of the visual field values. That was the range of the OCT values. So our eyes fell into this box here. All right, so here's our Heidelberg report for one of these eyes. You can see that the global thickness here, the average thickness is 32 microns. The visual field, if we blow this up, is almost minus 25 dB. If you plotted that person on this plot, they'd be way down here someplace. Right? Not an eye that by traditional wisdom would be a candidate to be followed by OCT. But what I'm going to argue is if you've got a portion of the visual field that's better than minus 8 or minus 10 dB or so, you're going to be able to use the OCT just fine. So here's a 10-2 in this patient. That should show up on the OCT. So in most eyes with advanced glaucoma, a region of the retinal nerve fibrillary remains as long as there's some preserved function someplace on the 24-2. All right, so let's blow this image up, right, and put our model on top. Okay. So the 10-2, let's just relate this now. So this is plus or minus 8 degrees. This is plus or minus 8 degrees. So let's put our model on top so that this region inside the model, right, on the circumpapillary plot goes from here to there. So this is the region you want to worry about if you're trying to preserve this part of the visual field. And again, remember, this patient's average value is way over here. Look at all the tissue here. Let's blow it up. This is what you want to follow. See, the damage here is marching towards fixation. You want to preserve this. You want to preserve that. Okay. Again, in most eyes, a region of the peripapillary retinal nerve fibrillary remains. So here's another eye. Global thickness here, 54 microns. Minus 22 dB mean deviation. That point would fall right about here, right smack in this region. Notice that it looks like something might be preserved here on the 24-2. There it is there at one point. Also, it looks like some preservation here, and there it is. All right. Let's blow up the circle scan image. This region right here corresponds to this region there, and this region over here corresponds to this region over here. You can take a better look at the 10-2. This area here, again, is this area here. That's what you want to preserve. Well, you want to keep that too, of course. All right, let's blow it up. Look at the beautiful picture. You can watch this carefully and see if you're preserving that portion of this patient. And again, this point's over here. Okay. So I told you we started a study with 36 eyes. Only 4 of the 36 so far would be hard to follow with an OCT. One showed no sign of retinal nerve fibrillary because all the points in the field were worse than minus 10. And then 3 had some remaining retinal nerve fibrillary, but not clear enough to follow. Finally, just briefly, it's often said that OCT is not useful for high myopes. That's not true. It can be used, but once again, you want to ignore the metrics. So it can be useful, but you need to ignore metrics such as global and quadrant thickness because they depend on healthy controls with refractive errors better than plus or minus 6. And you want to look at the circle scan. So here's an eye with peripapillary atrophy, right, minus 13.5 diopters. Here's our version of the Heidelberg report. And again, I want to make the point that a good circle scan by itself will allow diagnosis. So let's blow this up, right? And what do you see here? Well, this peripapillary atrophy is showing up as this bright spot here, but you can still see this. In fact, you can actually see you've got some epiretinal membrane there. This big defect here is right here, and you can see that's real, the tissues, and you can see thinning here as well, and that's going to be smack in the macula. So I don't need anything other than this to say that this eye has optic neuropathy that's affecting the macula as well as the region outside the macula. It's also affecting the upper disc or lower visual field. So, in fact, you can confirm it. Here's a 24-2, more or less as I described it, with both upper and lower field defects that clearly are going into the macula. That point corresponds to that point about, that point to that point. So everything between here is between here and here. 10-2, we can hone in on the macula. Here's our model. This point here would be right here. That point there would be that point there. So everything within this colored region here is between here and here. It's this region right here. Right, which again, you can see the details that you can follow over time. So often a good circle scan by itself will allow diagnosis. Here's another example, peripapillary atrophy. And here's the, is this patient normal? Absolutely, it looks normal to me. I mean, if I only had this by itself, I would say definitely normal. Again, this bright spot's due to the peripapillary atrophy. But look at the thickness of the retinal nerve fiber layer in there. And here are the visual fields, as predicted, clean. Sometimes you're going to want to look at the retinal ganglion cell and retinal nerve fiber layer maps too. I mean, in fact, I do it all the times, but sometimes you're going to need it over and above a good circle scan. So in this case here, I think that's real. You may get worried because the contrast is so terrible in this image in places, but this all looks real to me. But if I want to confirm it, this is actually extending into the macula, so the ganglion cells should be affected. Well, here it is. Here's the thinning of the ganglion cells. And then you can see thinning up here as well, and that would correspond to about here. Okay, so in this in a study that we presented at ARVO in 2017, I was able to correctly assess 93 of 96 eyes with high myopia using just the OCT scan. So in general, the point being that scan the high myopes. You have to be a little careful in doing the scanning, but if you do it carefully, you're going to be able to, in most cases, use the OCT. So I just want to leave you with one final thought. And the thought is that the glaucoma specialists are not making optimal use of this incredible technology. They should be examining the scanned images. Right? And to bring that point home, I want to compare my the OCT of my eye to the MRI of my brain. And to make the point that the resolution here is about 100 times better than the resolution of an MRI scan. To illustrate that, if I took this and scaled it down, this is how much room this would take here. And if you blew this up, you'd see nothing but gray. Right? 100 times better resolution. Now, don't be worried about this. This is this is actually a non-symptomatic fat, a little piece of fat that's between my hemispheres. But let's suppose, just for the sake of discussion, let's suppose that we're a tumor. Now, would you want the radiologist to have a program where they segmented the outer edges of the brain, where they then segmented the hot spots the way the OCT algorithm segments the retinal nerve fiber layer, and then indicates with red and green where the normal and abnormal regions are, and then maybe chunks it up into chunks and creates a pie chart. This is actually an OCT pie chart, something like this. And then have the radiologist read this to find out what's happening with that. Well, that's what we're sort of doing with glaucoma, right? Instead, what the radiologist would do is blow this up, look at the edges here, and then see how that's changing over time. The same way I'm suggesting we look at an OCT and carefully look at how the defects might be changing over time. Now, what about structure-function relationship? Well, the neurologist working with the radiologist or the neuroradiologist would say, well, gee, that's in the, that looks like it might be in somatosensory motor area. So would you want my neurologist to take a look, to average the sensitivity across the skin, and do something similar to a mean deviation? Or would you prefer, or I would prefer, if they went in and took the area of interest here and said, "Ooh, so it's probably the thumb," and then made sure they did a careful analysis of the sensitivity of on my thumb. All right. So to end with, are we in the middle of a paradigm shift? The answer is, I sure hope so, because I think our patients will be better served. Thank you for listening.